Yeah, good evening, everyone. I welcome you all for the Tuesday webinar from Critical Care. What we are doing, like since last 2 years or so, we try to get something interesting and maybe thought-provoking topics every week. And nevertheless, today also we have something like that. Today's topic is PLEX or plasma exchange, a game changer, which we know like nowadays slowly this kind of plasma exchange or different form of hemoperfusion is gaining more and more popularity. Newer things are getting adding up as a category one, or where we should consider these cases the plasma exchange and all more often. So to know more about this, all these things, we have two expert panelists with us. Dr. Shamee Shastry. She is the professor and head of Department of Immunology and Transfusion at Kasturba Medical College, Manipal. She is secretary of Asian Association of Transfusion Medicine in Indian chapter. She had many awards and achievements. Our second expert panelist is Dr. Divya Setya. She is a consultant transfusion medicine at Manipal Hospital, Jaipur. She had many degrees and fellowships abroad, like in Seattle and the Washington Medical Center. She had and 50 publications in national and international journals. Welcome, ma'am, and I welcome you both of you to take out time from your busy schedule and uh, like be here and giving us the things what we are being in the critical care specialty to know, like what we should know when it comes to a plasma exchange and all. To have overview about like what plasma exchange, how we are doing, what are the indications and all. Our Dr. Isha Polavarapu, she is our transfusion medicine consultant at Yashoda Hospital, Hitech City. She will take us through maybe in 10-15 minutes. So we'll have some idea what exactly we are looking at when it comes to plasma exchange. Afterwards, we can take questions and we can discuss further when it comes to plasma exchange with our expert panelist and our speaker. So, and I will request all the attendees to post your questions in the Q&A section so that we can take up those questions either in between if it is really relevant or maybe at the end of the session. With that, I want to hand over the session to Dr. Isha. Go ahead, madam. You can present you.
Thank you, sir. Yeah. Is my PPT?
Yes, ma'am, it's visible. It's clear.
Yeah. Okay, sir. So good evening, everyone. I'm Dr. Isha. I'll be talking very briefly about therapeutic plasmapheresis or PLEX. What is it? What is the rationale behind doing it? Few indications, because it is an exhaustive list, and some of the cases where we did where PLEX was useful. And then we'll move on to panel discussion. So therapeutic plasma exchange or PLEX denotes the selective removal of patient's plasma which has the pathogenic substance and replacement with either colloids or crystalloids. What is the rationale behind it? The goal, if we have to remove antibody with harmful specificity, for example, autoantibodies, removing proteins with harmful physical properties in case of hyperviscosity or immune complexes, to remove non-antibody toxins, as in the case of low-density lipoproteins, and in case of TTPs, we know to correct the deficiency of the plasma factor. A few prerequisites. There are different instruments being used for centrifugal plasma exchange. The machine that we currently have at Yashoda Hospitals is Thermopenpal spectroptia. There's also Fresenius Kabi Comtech and also Hemonetics. Vascular access, it can be done through central venous catheter, AV fistula, or peripheral vein access also if the vein is good. Duration, approximately 1 total plasma volume is processed within 2 hours. Replacement fluid, again, depends on what is the case we are dealing with, normal saline or albumin or plasma, it depends on the case. So the more we process, the better the plasma exchange. That is not the case. There's something called as exponential decay. So exchange volume, if one total plasma volume is processed, there's a reduction of only 35% of the initial value of the offending substance. If we process 2 total plasma volumes, then there's a further reduction of only 15%. So there is diminishing effectiveness of the procedure. So usually 1 to 1.5 times total plasma volume exchange is preferred, not more than that. So the most common molecule being targeted is IgG. It is 50% in extravascular space, 50% in intravascular space. So once we do 1 to 1.5 times TPV, it removes about 60 to 75% of the IgG material. But there's a rebound phenomenon. The shift of extravascular IgG into the intravascular compartment in 1 to 2 days after every TPE. So a reduction of 80 to 90% can be obtained with 4 to 6 plasma exchanges with 14 days. That's why alternate days procedures are also suggested. So since we are removing a lot of plasma, there are bound to be some biochemical changes. So platelet count will decrease marginally about 30%, but it will come back to normal within 72 hours. The proteins, individual protein levels and also individual factor levels will also transiently decrease. They'll all come back to normal within 24 hours. But fibrinogen alone takes about 72 hours to come back to normal. There's not much difference in the electrolyte levels with plasma exchange. Coming to a few differences between centrifugal plasma exchange and membrane plasma exchange. So when I'm talking about plasma exchange here, I'm talking about centrifugal method, because from transfusion medicine point of view, we have always been using the centrifugal method. But if you do on the dialysis machine, it is called membrane TPE. They do with a capillary membrane filter. In centrifugal method, the separation is based on the specific gravity and the mechanism is centrifugal force. So blood flow in centrifugal TPE is anywhere between 10 ml to 140 ml. Membrane TPE, it's high, 150 to 200 ml. Plasma extraction, this is called total plasma extraction. This is 80 to 85%. In fact, Spectroptia, the machine that we have currently, claims about 93% total plasma extraction, and membrane, it's only about 25 to 30%. When I'm saying plasma extraction, I'm saying the amount of plasma that is removed in relation to the total amount of plasma processed. So if the plasma extraction rate is low, that means total blood volume, more amount of total blood volume needs to be processed. That in turn leads to more amount of anticoagulant also going into the patient. So in centrifugal TP, since the plasma extraction rate is very high, the procedure time also reduces. The other difference, molecular weight cutoff, it's not applicable in centrifugal TPE because we are just separating and we are not filtering out anything. We are just separating it based on specific gravity. Whereas in membrane TPE, cutoff is 3 million Daltons. Again, anticoagulant, there is a difference. Membrane TPE, it is heparin, and centrifugal method, we are using citrate. So which conditions can we do plasma exchange? There are some guidelines that we are following. The guideline we are following is called ASFA classification, where they divided the disorders into 4 categories. Category 1 is where plasma exchange is accepted as the first line therapy, either as a primary standalone treatment or in conjunction with other modes. Category 2 is where it is accepted as second line treatment. Category 3 is where the role is not yet properly established. So decision making should be individualized, case to case basis, depending on the clinician. And this category 4, where there are certain disorders in which plasma exchange is actually harmful. So there's also something called as a grade system where they have divided. It's 2 grades, grade 1 and 2, and under each grade there is ABC. So coming to grade 1A, they mean strong recommendation with high quality evidence. What is the evidence? RCTs without important limitations. 1B is moderate quality evidence, RCTs with important limitations. Grade 1C is low quality but strong recommendation. where the evidence that we have is only observational studies or case series. Grade 2A, 2B, 2C is also the same thing as 1A, 1B, 1C, just weak recommendations. But the methodology that they have followed is the same. So there is quite an exhaustive list of all the indications in ASFA 2023 guidelines. I have covered only a few things. Coming to neurological disorders, category 1 indication, plasma exchange is category 1 indication in AIDP, CIDP, acute myasthenia gravis, and demyelinating polyneuropathies. Category 2 indication in Lambert-Eaton myasthenic syndrome, long-term myasthenia gravis, acute disseminated encephalomyelitis. Hematological disorders is category 1 indication in TTP and in TMA, which is factor H autoantibody associated, TMA, which is drug associated, particularly in ticlopidin and clopidogrel. A category 2 indication in cold agglutinin disease, and category 3 indication in warm IHA, also TMA, which is infection associated. Nephrology, FSGS is also category 1 indication. Goodpasture syndrome is category 1 indication. Vasculitis, which is ANCA associated, is category 3. Coming to acute liver failure, 2023 classifies TPE with high volume as category 1 indication, and TPE which is being done with standard volume as category 3 indication. In liver transplantation for ABO incompatible live donor and renal transplantation, it is category 1. In cardiac transplantation and lung transplantation for desensitization and AMR, it is category 2 and 3. Coming to acute toxins, venom, and poisons, it is still in category 3, but mushroom poisoning alone, it is in category 2. So coming to a few cases. Case 1, we had a 12-year-old boy who presented with complaints of vomiting, easy fatigability, and oliguria. The lab parameters showed signs of anemia and signs of hemolysis in peripheral smears. There were deranged RFTs and elevated LDH. Renal biopsy was done, which showed TMA with no evidence of necrosis or crescents. As part of evaluation of AHUS, anti-factor H antibody levels were done. They were found to be very high, around 8,000. Patient was diagnosed to have complement-mediated TMA or atypical HOS. So TP was initiated, about 10 procedures were done of conventional TP. When I mean conventional TP, I'm talking about centrifugal plasma exchange. And patient went into remission for about 4 years. He later presented to us after 4 years with signs of relapse. There were signs of, again, anemia, thrombocytopenia, hemolysis, elevated LDH. Again, RFT was elevated. So conventional plasma exchange was initiated, a total of 64 procedures, that is 8 cycles. Each cycle involved 8 procedures. This was done on OP basis on alternate days. So each time the patient would come, we would do 8 procedures on alternate days. And in each procedure, 1.3 total plasma volume was processed. As we discussed previously, TMA complement mediated comes under category 1 of ASFA. So following each cycle of TP, that is after 8 procedures, there was 52% reduction in the anti-factor H levels, but remission was not achieved. So decision was taken to start something called cascade plasmapheresis or double filtration plasmapheresis. So this EvaFlex filter was attached to the centrifugal plasma exchange machine, and instead of removing the plasma and replacing with fresh plasma, because at this point we had done around 64 procedures, and slowly patient was developing allergic transfusion reactions also to the FFP. We didn't want to replace with fresh plasma. So we were just filtering out the plasma with the cascade filter. So around 8 procedures were done, and in each procedure, 2.1 total plasma volume was processed. After each procedure, we noticed a 73% decrement in the anti-factor H levels. So after 1 procedure of cascade plasmapheresis, there's 73% reduction, whereas after 8 procedures of conventional TP, there was 52% reduction. Patient finally went into remission after 8 cycles of cascade plasmapheresis. So coming to the article on the left, it is an international consensus approach published in Pediatric Nephrology to the management of atypical HUS in children, where they suggested eculizumab to be the first line of therapy. If it is not available, plasma exchange should be started as soon as possible. If plasma exchange is not possible, then plasma infusion at least should be started. Coming to the right, this was an article published by PGI Chandigarh, where they analyzed 30 pediatric patients for the safety and efficacy of PLEX in pediatric atypical HUS. A total of 169 plasma exchange procedures were performed, and in that, there were 16 patients were complete responders, 5 were partial responders, and 3 were non-responders. So they concluded that TP is a safe and effective therapeutic modality in pediatric atypical HUS if instituted early in the course of the disease, with a minimum of 4 to 5 procedures. Coming to case 2, we had a 67-year-old male who presented with difficulty in walking and standing for about 10 days. He also had difficulty in getting up from sitting posture, buckling of knees were present. There was also difficulty in gripping objects. There was no significant medical history. On examination, the tone was found to be normal in upper limbs, and also hypotonia was noticed in lower limbs. So as we can see, the deep tendon reflexes were all diminished and sensory system was also affected. The nerve conduction study revealed bilateral severe sensory motor polyradiculoneuropathy. CSF fluid analysis also showed raised protein with no cells. So this was a case of AIDP, which falls under category 1 as per ASPA guidelines. So we did 5 cycles of plasma exchange as recommended by the guidelines on alternative days. Both albumin and FFP was used on a combination basis, and 1.2 total plasma volume was processed in each procedure. So patient showed improvement after 5 cycles. Physiotherapy was provided and he was subsequently discharged. The article on the left was published by AFMC, where they did a retrospective study of 57 GBS patients who were treated with plasma exchange. They assessed the GBS disability and Medical Research Council muscle strength scoring. So after doing for each patient on 5 alternate day, plasma exchange was done. And after assessment, they found both the scores have improved, and they concluded that TPE to be an effective mode of treatment for GBS. On the right, we have an article where they did a retrospective analysis of 7.5 years of data with 56 patients of GBS. Again, TP provided significant improvements in both GBS disability scores and MRC muscle strength scores. TP treatment significantly decreased the time to regain walking ability and decreased the proportion with walking disability after 4 weeks. The next case, we had a 56-year-old female who presented with complaints of burning micturition, increased frequency of urination, and lower abdominal pain. There was also a history of fever and vomiting, history of loss of appetite. The peripheral smear showed signs of thrombocytopenia, also schistocytes. There were signs of hemolysis. You can see there are schistocytes in this picture. There is NRBC and there's also polychromatophils. There was elevated creatinine and raised LDH levels. Platelets, at least 8 to 10 platelets we should see per field. Here we can't see anything, so there was thrombocytopenia. So ADAM-TS 13-factor activity was tested. This was done on semi-automated ELISA platform. Day 1, it was found to be 1.2%. Slowly, progressively increased after we started plasma exchange. On day 19, it was found to be 9.6%. ADAM-TS 13 inhibitor levels was 7.9%, so it ruled out acquired TTP. So a total of 6 cycles of plasma exchange were done. TTP, as we know, is category 1 indication. In each cycle, 1.2 total plasma exchange was processed. And TP was continued until the LDH normalized and also platelet count improved in the patient. On the left, this was an article which studied 163 patients with TTP. which on whom plasma exchange was performed. This was studied over 5 years from 10 centers in Turkey. They summarized that TPE is extremely effective for both primary and secondary TTP. And the addition of steroids to TPE has reduced the mortality rate significantly in their study group. The article on the right was published from Mayo Clinic, where they claimed the plasma that PLEX in TMAs other than TTPs, that is TMA which is complement associated, HSCT associated, malignancy associated, HELP syndrome associated, these all could benefit from TPE, but they also said only as of now only case reports and case series have been published, and for RCTs are needed for further conclusive benefit. The next case, we had a 46-year-old male who's a known case of alcoholic hepatitis. He presented with abdomen distension, jaundice, swelling of feet. On examination, there was icterus and pedal edema. Abdomen was dilated, and also abdominal edema was present. In view of worsening creatinine, urine output, and hyponatremia, 2 cycles of SLED were started. A patient had fever, antibiotics were escalated. In view of persistent hyperbilirubinemia and coagulopathy, PLEX was started. So in this case, we did standard volume plasma exchange. That is, 1 total plasma volume was processed per procedure. Acute liver failure is again a category 1 indication. So we did plasma exchange. As you can see, after doing plasma exchange, the bilirubin levels started falling down and they became normalized. We did 3 procedures on consecutive days. So coming to the evidence behind acute liver failure and plasma exchange, the evidence is varying. First, we'll look at the article on the right. This is a mega RCT which is published from across Europe by Larsen et al. In 2016, where they claimed, this is an open RCT, where they claim that high volume plasma exchange improves the outcomes in patients with acute liver failure by increasing the liver transplant free survival. The article on the left, this is the CMC protocol, which is published recently, 2021, where they studied over 25 patients with severe alcoholic hepatitis. And they said, they concluded low dose plasma exchange and low dose steroid improved the 1-year survival in patients with alcohol related ACLF and severe alcoholic hepatitis compared to those receiving standard medical treatment. And this may also be a potential bridge treatment to liver transplantation. CMC protocol, when they say low volume plasma exchange, they processed anywhere between 50% to 75% total plasma volume, not more than that. So coming to the most recent article published, this was again an RCT published by ILBS Delhi, where they studied 42 patients and they concluded that standard volume plasma exchange, that is anywhere between 1 to 1.1 TPE total plasma volume, it improves the outcomes in patients with acute liver failure. The last case of the day, we had a 26-year-old antenatal mother, G2P1L1, who underwent an emergency cesarean section at 34 weeks POG in view of preeclampsia and HELP syndrome. On POD1, the patient developed sudden onset of breathlessness along with decreased urine output. Peripheral smear showed normocytic normochromic picture with polychromatophils and the presence of schistocytes. This was suggestive of microangiopathic anemia. On examination, patient had pallor, icterus, and pedal edema. TMA was diagnosed on POD4, for which we initiated PLEX. This is a case of postpartum thrombotic microangiopathy, which is a category 3 indication as per ASFA. The decision to start PLEX was taken in conjunction with the critical care department in this particular case. A total of 6 cycles of plasma exchange were done on consecutive days from POD5 to POD10. So after 6 cycles, you can see the LDH levels dropped down and also the platelet count increased to above 1 lakh. These parameters also show the improvement in hemoglobin, hematocrit, platelet count, normalization of LDH, and improvement in urea and creatinine following plasma exchange. Patient recovered following treatment. Duration of stay in the hospital was 26 days. Within 1 month, all her lab parameters were normalized. So there are a number of case reports and case series published from within India showing the efficacy of plasma exchange in postpartum TMA. But here we have a special report, management of TMA in pregnancy and postpartum. This is a report from an international working group where they said PLEX can be initiated when a patient with TMA diagnosis has an atypical presentation of preeclampsia or HELP syndrome, has life-threatening neurological symptoms, or profound thrombocytopenia. In other cases, after 24 to 72 hours of close monitoring, if improvement of thrombocytopenia and hemolysis do not occur, then plasma exchange can be started. So that's it with the cases. Thank you. Over to Misra, sir.
Thank you, ma'am. I think was nicely summarized, and with some good cases also, what real cases, what you have told us or shown us, how the plasma exchange is effective in different form of medical disorders. As we all know, like most of our ICUs, when we think of plasma exchange, maybe the most common condition where we do plasma exchange is maybe GBS, AIDP, then maybe myasthenia crisis. Sometimes we consider plasma exchange when it comes to different forms of connective tissue disorder flares, mostly SLE flares. Sometimes in catastrophic AFLA also we thought of plasma exchange. So before going into the complicated things, for the best of interest of our students, I'll just ask, or maybe briefly you can tell. I know you have covered everything in your presentation. Like just briefly, for our critical care people may not be good enough for the transfusion because you are the bosses when it comes to plasma exchange. How to decide about the dose? You have shown already. Like then how many cycles we should decide? Like as for ASPA guideline, I know it is 5, but different disorders may have different number of cycles when it comes to plasma exchange. And how to decide about which will be the best replacement fluid when it comes to, just briefly one line for the students.
So should I take this or the panelist?
Yeah, please, madam, you can take it.
Okay.
Then we'll come to.
Yes. So ASPA guidelines also recommends the type of the replacement fluid that should be given for each condition when they have listed out the indication. For example, plasma can be used as replacement fluid in case of TTP, where we are replacing the deficient factors. But albumin is recommended in most of the neurology cases rather than plasma. Plasma is only suggested if we are suspecting, if we are doing continuous plasma exchanges and we are noticing a transient coagulopathy, then plasma can be added on. Otherwise, albumin is the preferred choice of fluid or preferred choice of colloid in all neurology cases. Coming to how much we should process, most of the neurology cases, only standard volume plasma exchange has been recommended, 1 to 1.2 total plasma volume. See, total plasma volume again has to be calculated based on the hematocrit and the total blood volume that I have shown in the presentation. So 1 to 1.2 total plasma volume. And why we are doing on alternate days is only in case of GBS, ASPA has said daily or alternate days. The decision has to be taken by the a clinician in charge. Sometimes in GBS cases, we do the first 3 procedures can be done continuously, and then we can go to alternate days. But otherwise, alternate days we are suggesting because we notice a rebound phenomenon. And we have to deal with that rebound at some point. That's why we suggest alternate days.
Yeah, no, actually, when it comes to antibodies, different antibodies which is getting, we can only remove the things which are there in the blood. So once we remove around 60-70% with our first plasma cycle, then again those things which are there in the tissues will come back to the blood. So it takes some time, and that is the rebound phenomenon that need to be done maybe every day or every alternate day. Most of the time we are suggesting every alternate. If I am not wrong, that is what, no?
Yes, sir.
Yeah. I think you have told clearly about the centrifugal which is, I believe, maybe the best way to do a plasma exchange. But most of the places in India, because a lot of people who are attending our this webinars are from different parts of India, maybe from smaller cities also, where they may not have centrifugal machines. So, is there any specific things that need to think of when it comes to membrane based plasma exchange if they don't have a centrifugal machine?
So membrane-based TP, yes, if in a resource-poor setting, since we already have a dialysis machine, if we just need a plasma exchange, it is easier to go on membrane TP also. The only difference between that and this is there have been cases of filter clotting which we should be which we should be watchful for, and in almost all cases dialysis catheter is needed. In centrifugal plasma exchange, yes, if the veins are good, sometimes we can do on peripheral vein access also. But centrifugal plasma exchange machine can be used for other therapeutic procedures also, like cytopheresis or stem cell collection or red cell exchange, whereas dialysis machine can be purely used for only therapeutic plasma exchange. But otherwise, it's just the filtration method. The difference, main difference is the filtration.
Dr. Shamee, can you and Dr. Divya, can you just like switch on your videos? So, madam, do you want to add something when it comes to membrane plasma exchange? Do you believe, like in membrane plasma exchange, we can lose other like proteins or something else more than your like what we are targeting? Are we losing anything else when it comes to membrane plasma exchange compared to centrifugal?
Yeah, efficiency wise, centrifugal plasma exchange is much better because we are removing the immunoglobulins, we are removing the antibodies, and we are removing the toxins here. Whereas in case of membrane plasma exchange, it is just a filtration. So the main pathogenesis, whatever is involved with neurological or hematological condition, where we do a TPE, the agent, the toxin, or the antibodies are totally removed. So the efficiency wise is much better. And another point that I would like to add is for pediatric patients, we can use the centrifugal method with the much more safer. It is safer, and with safety precautions we can do it, because the blood flow rate is quite high with the membranous method. The complication rate is much higher. That's what we have seen. And the side effects wise, the efficiency wise, definitely TPA with the FRSS machine is better.
Nicely narrated, man. We'll come to little complicated things now, like what we usually face when it comes to ICUs. Let's say, like in GBS nowadays, most of the people they prefer maybe IVIG over plasma exchange because it is easier to like just transfuse IVIG than thinking of placing a SDC than going for a plasma exchange. And like there are many controversies when it comes to, let's say, GBS or even myasthenia crisis. Like, is there any literature where it shows like maybe IVIG? I know the literature says both are equal, but what is your like personal experience when it comes to IVIG versus plasma exchange, Divya ma'am?
Sir, as far as my experience goes, the more fulminant the course of the disease, the more is the utility of plasma exchange in that particular patient. So IVIG and TPE both have been shown to be equally effective, but once IVIG is given to the patient no longer becomes a candidate for therapeutic plasma exchange. So even if the IVIG doesn't work in the patient, you won't be able to get much benefit if you start TP after giving IVIG. So that is the call of the treating physician as to how fulminant he sees the course of the disease is. That's it.
Because why I'm asking, madam, actually we have two interesting cases. Maybe for this topic only we have two cases, or I don't know. One case of GBS, both are GBS, which are permanent. They like the progression was very, very fast. In one case, we gave IVIG, like 5 days we gave, there is no great improvement. Actually, he is now on ventilator. We have done a tracheostomy. Similarly, one more case is there, maybe more fulminant than the first one. Within 2 days, he went into ventilator because the respiratory involvement was significant. For him, actually, we have done already 3 cycles of plasma exchange, but there is no great improvement till now. He is more or less same on ventilator without much of improvement. Like, do you believe, Dr. Sami, like, let's say in GBS, where it's like Dr. Divya told nicely that if you give IVIG, if you do a plasma exchange after giving IVIG, you will be removing the IVIG. So, like in these cases, like let's see, there may be many permutation combination. Actually, few questions are there in the chat box also. Do you believe we should start with plasma exchange if patient is not responding? At least we have a scope of giving IVIG. I know there is no the data doesn't support. Like if you do a plasma exchange or IVIG, after maybe IVIG doing a PLEX or after PLEX giving an IVIG doesn't offer better patient recovery. But in your experience, do you believe we should do plasma exchange first? Then, if at all patient is not improving, then think of IVIG. Or in this cases, let's see, ASPA guideline is saying only 5 cycles. Do you believe we can do more cycles if the patient is not responding?
Yeah, nowadays IVIG is clinicians are preferring IVIG as it is a non-invasive and easy to administer. In the mechanism of action of both IVIG and TPE is different. The TPE can give you the immediate effect. It reduces the antibody levels, autoantibody concentration immediately. So in patients with severe course, as Dr. Divya said, respiratory impairment prior to initiation of treatment or during hospital admission, in such cases, maybe you can begin with TPE and later start on IVIG, because IVIG action may take some time, whereas TPE effect is quite immediate. So the decision needs to be done case to case basis, is my opinion.
I think there was a case, like there was a question there that in ANCA vasculitis, like how we should go for PLEX, how frequently we should do. Is there any difference between when it comes to ANCA vasculitis versus GBS and other conditions? Divya ma'am.
So, sir, ANCA vasculitis, if it is accompanied by diffuse alveolar hemorrhage, then we need to treat as soon as possible and as aggressively as possible initially. So, probably the initial 3-4 procedures we would like to do on consecutive basis. And then probably we would see the response, and then we might want to shift on alternate basis. But as far as other complications of ANCA positive vasculitis are concerned, and if the patient doesn't have diffuse alveolar hemorrhage, then we can consider alternate day exchanges.
Okay, ma'am. I think the question what I've asked before, like to just continuation with the question. Actually, one question was there in the chat box. Let's say we have given IVIG in a patient of GBS and it is refractory. Patient is not improving after IVIG. In those cases, if you plan plasma exchange, what will be the ideal time to start plasma exchange? After how many days? Immediately or after few days? Or is there any guideline to suggest when?
Sir, so IVIG has a half-life of more than 20 days. And once any sort of drug achieves that T-half, and after that, if we do a plasma exchange, there is not a significant portion that is removed after plasma exchange. So once we achieve that half-life, after that, we can do plasma exchange. But the thing is that how do you wait for those 20 days if the patient has respiratory muscle weakness? So usually what they say is that plasma exchange needs to be done within the first 4 weeks. So once you give IVIG, wait for a few days, and then probably you can start plasma exchange, but that has to be done within 4 weeks?
Now, within 4 weeks, when it comes to maybe GBS is like the disease process or the pathology of the disease itself is it progresses within the first 4 weeks. After that, we usually as the uh, disease process then plateau, then there will be improvement. So maybe after 4 weeks, when the disease is not progressing anymore, any form of treatment, let it be IVIG or plasma exchange, doesn't make much sense. So, like, is there a what is the experience and maybe the guidelines suggest regarding hypertriglyceridemia related acute pancreatitis? Sami ma'am.
Yeah, in our center, we have not done therapeutic apheresis for acute pancreatitis. However, as per guidelines, nowadays we have adsorption columns and the triglyceride levels can be brought down using the columns. Even with simple plasmapheresis, plasma exchange, it is quite possible, but use of columns will be more efficient.
So, like one more actually dilemma when it comes to, let's say, in ICUs. So again, more of like our GBS and myasthenia. See, SLE flare or let's say in your ANCA vasculitis with diffuse alveolar hemorrhage or it may be a catastrophic APLA. If you see the guideline, they suggest more of plasma exchange. But if you see most of the right now the physicians or let it be our rheumatologists also, they are tending towards IVIG. Like, do you believe like a plasma exchange should score over the IVIG in this kind of conditions? Divya ma'am.
Sir, ANCA positive vasculitis with diffuse alveolar hemorrhage does definitely benefit with plasma exchange. You give FFP as replacement fluid and it works wonders. As far as ANCA positive vasculitis is concerned, without the presence of DAH, then it is a category 3 indication. And it might or it might not benefit the patient. And again, because it is an invasive procedure, people might want to try other modalities before they offer the patient plasma exchange.
Like, let's say sometime we give, because one more problem when it comes to this kind of, this a different form of connective tissue disorder flares and all, where the patient will have all the symptoms of sepsis also. It becomes very difficult clinically to know that because most of the time they will be on immunosuppressant and all. So it becomes very difficult. Sometimes it is only flare or flare with sepsis or it is sepsis itself. In those kind of conditions, like we have actually being a intensivist also, and most of the people like me will have a fear that when we do a plasma exchange, it can flare up sepsis. Is it so? Sami madam and Divya madam, anyone can take the question. Do you believe like plasma exchange, because we are removing all the antibodies, not only the maybe the antibodies which is causing the disease, other antibodies will be required to fight the infection. Like, is it flares to sepsis? Is there any guideline or something to suggest?
If we look at the ASFA guidelines, now the sepsis is one of the indications for plasma exchange, because in sepsis, the cytokines or the metabolic end products, the toxins, when we do plasmapheresis, it gets removed. And even in patients with the multi-organ failure or critically ill, when we remove all these toxins, then the microvascular circulation improves. They say it can be a therapeutic modality.
But Divya madam, anything you want to add or Dr. Isha?
Sir, the only chance of infection where you would be a little apprehensive to start any sort of therapeutic apheresis in a patient of sepsis is because of the catheter. You would think that the catheter might lead to, with handling, it might lead to infections. But as far as sepsis is concerned, ma'am is very right. that ASFA actually recommends doing plasma exchange in cases of sepsis because it helps the patient from SIRS.
This is actually my favorite topic when it comes to sepsis and different form of hemoperfusion. And maybe if you see hemodialysis, then you remove perfusion, and the last thing what you can do to remove everything will be plasma exchange. If you see like that, no, like maybe from 50%, 70%, 100% will be plasma exchange. So in sepsis, we know like there are a lot of cytokines, chemokines, and all those things. There is like SARS, CARS. So is there like ASPA guideline is suggested at what time of sepsis we can think of plasma exchange? Like any literature on that?
Sepsis with multi-organ failure.
Okay. So this is, you see, like now hemoperfusion is also coming in a big way when it comes to different form of hemoperfusion, where they remove the cytokines and chemokines, both like SARS and CARS, means anti-inflammatory and pro-inflammatory cytokines can be removed. And like till now, there is no significant literature to suggest that it is going to help the patient, because we are still in a dilemma to use or not to use or when to use. So plasma exchange, which can remove everything quite effectively, and you can replace the whole thing with a normal plasma. That's why actually I was more fascinating. Is a fascinating thing when it comes to plasma exchange, maybe in sepsis, how it is going to be useful. Maybe I think it is in which category, madam, right now, when it comes to ASPA?
Category 3.
Category 3 only. So it is still maybe in future we'll have more idea when it comes to plasma exchange and sepsis. Why I have asked this question is, if you see most of our ICU, most of our consultants, they will be afraid of doing plasma exchange whenever they believe the patient is in sepsis. They will tilt towards IVIG, believing that IVIG have some better protection when it comes to sepsis than plasma exchange. So now, as with the ASPA guideline of category 3, we'll be little like proactive doing a plasma exchange and see how the things will be more often. Maybe we can compare our historical patients and see how plasma exchange scores over. So there is like one question from one of the attendees, like how do we decide about high volume plasma and low volume plasma? Like what will be like deciding factor about high volume and low volume plasma exchange, and what should be the dose, and what is the role in high volume plasma in acute liver failure? Isha madam, you want to take it?
Sir, the evidence in acute liver failure, especially regarding how much plasma to be processed, it is varying. As I have shown, initially, right now, as per ASPA, high volume total plasma exchange is in category 1. And as per ASPA, standard volume total plasma exchange is in category 3. But two major Indian studies, the most recent ones, one is the Vellore protocol and second one is the ILBS protocol. Both of them have shifted over to standard volume and low volume plasma exchange. And they are claiming after RCTs, these are minor RCTs with 25 to 40 patients. They have observed that standard volume and low volume is equally effective to process for plasma exchange to be a bridge for liver transplantation. So this has to be done on case-to-case basis. Initially, we were doing high volume plasma exchange. Now we have shifted over to standard volume plasma exchange. So it really depends on the treating medical gastroenterologist in this case. Because
standard means we are talking about 1 to 1.2 plasma volume.
Yes.
Correct, no? And
Low
high volume will be?
High volume is 1.5 to 1.6 we'll do, sir. But low volume CMC protocol, they are only doing 50% to 75% of total plasma volume, not more than that. In all their 25 patients, they have done only that much.
Like when we do this high volume plasma exchange, or maybe our normal volume plasma exchange, what are the most common complications we can see?
Okay, complications, most common complication is because we are giving citrate as an anticoagulant and it reduces the ionized calcium level. So we see hypocalcemia first, that we combat with giving intravenous calcium infusion. Slow IV infusion of calcium gluconate will be going on in this patient. Second, something related to the line. If the line is not proper, then vascular access can be a problem. In some patients, FFP can cause allergic transfusion reactions. Albumin doesn't cause any reaction, but I happen to witness an albumin causing anaphylaxis, which I won't forget. So it can happen related to the replacement fluids also. So these are the most common complications we notice during plasma exchange. Hypotension also, if we don't adjust the volume of the fluid being replaced, if we don't adjust it properly, then also hypotension also we can see in these patients. We have to be vigilant about that.
Now, apart from this acute liver failure, is there any role of plasma exchange when it comes to acute and chronic liver failure patients? Like maybe a decompensated chronic liver failure patient coming to our ICU. I think these are the patients which we see more often in the ICU than acute liver failure patients. Divya ma'am or Isha ma'am, anyone?
Ma'am can take it. Yeah. Okay. Acute and chronic liver failure also, as per ASFA, comes under category 1 indication currently, 2023 guidelines.
Well, like decompensated chronic liver disease, we can think of plasma exchange?
Yes. But they are claiming high volume. Whether to do high volume or not, again, is depending on the treating physician.
And in this kind of conditions, we believe the replacement fluid should be albumin in place of plasma, isn't it?
Yes, sir. Or we can choose a combination of albumin and plasma also. That is
how
what
to decide,
we were doing.
like you told one thing, like in maybe in TP where we want to give like proper plasma in those cases, other cases we prefer albumin. Like let's say in other cases like a GBS or a common case where we are doing a plasma exchange, how we decide, like let's say if we are planning to give both plasma and albumin, how we decide and in which percentage we give plasma and IVIG. Sorry, plasma and our albumins. Divya ma'am or Shamee ma'am?
Yeah, regarding replacement fluid, in a patient with normal coagulation status, then plasma needs to be avoided because it is a human product and can lead to a lot of reactions and adverse events. So albumin is preferred there. So first or second, two procedures we can do even without plasma infusion. If the patient's coagulation status is fine, then we need to monitor either using TEG or routine or traditional coagulation test. From third procedure onwards, there is a chance that the depletion of the coagulation factors, then we can introduce plasma products. And generally, in such cases, what we do is 50% albumin crystalloids and 50% plasma, which is given towards the end of the procedure. Whereas in liver failure or where there is coagulopathy, hypocoagulable state, for example, following hematotoxic snake bite or acute liver failure, there is a hypocoagulable state. In such patients, plasma is preferred. Or in case of TTP or HUS, where you want to supplement some plasma components, then CPP or plasma is preferred as a replacement fluid. So it depends on patient's coagulation status and the underlying pathology.
Yeah, nicely told, ma'am. I think maybe if you see different forms of poisoning also, now slowly if you see there are a lot of these hemoperfusion cartridges are coming, where we are like those things are being used in different form of poisonings, where selectively we try to absorb those poisons whichever is there in the blood. And what is at this point of time, is there any role of plasma X in different form of poisoning or maybe serious form of poisoning? We can remove the whatever poison is there in the blood at a time, like instead of doing heme absorption and all, and we can quickly remove those poisons. Shamee ma'am or Divya ma'am, anyone can take if you have any personal experience about poisonings and plasma exchange in those poisonings.
Yeah, we have done several procedures. One example that I would like to highlight here is about acute liver failure following yellow phosphorus poisoning. And now it's kind of become epidemic, because we see a lot of such cases. And our experience is it has really benefited the patients. We have done a case control study where we have taken 19 cases who underwent TPE following yellow phosphorus poisoning, and 17 controls. So following patients, the category who have received TPE, we have seen that there is 69% reduction in the mortality rate. And that's quite a significant number. And there was improvement in the liver function as well as the coagulation status in this group where the TPE was done. So our experience is definitely TPE has got a role in managing such cases, even for paracetamol or the other poisoning cases where there is acute liver failure. TPE definitely has a role.
Like maybe yellow phosphide or paracetamol, whatever cases you are quoting, ma'am, I think in all these cases, the patient may have acute liver failure. And maybe it is not removal of the toxin per se, maybe in acute liver failure, now it is a category 1 of plasma exchange, might be helping them, isn't it? Like, is there any other, like, let's say in ICU, we get paraquat poisonings or some other different form of poisoning, like where there is a role of hemoperfusion, but at this point of time, I don't think we have any literature on plasma exchange. Any idea, like, or any literature you have came across in plasma exchange in other form of poisoning, where we are not thinking about, like, there is a confounding factor of acute liver failure, which might be helped with a plasma exchange?
Yes, in case of mushroom poisoning or organophosphorus, their TPE is mushroom poisoning. I think it is category 2 indication. So definitely it is, these are the indications for TPE.
You want to add anything, Divya ma'am?
So, sir, there is sufficient data available about scorpion stings and snake venomation, and there is definitely a role of plasma exchange in these categories. What we need to understand here is that any sort of substance which has a low volume of distribution in the body and it is bound to albumin, any sort of substance, if fits this criteria, can be removed using plasma exchange.
That's what I think. Same question somebody is asking, like in heavy metal poisoning, can we do plasma exchange? I think they are all controversial topics. I think we don't have enough evidence at this point of time to comment in favor of against a plasma exchange. Maybe in future we'll be getting more and more literature supporting maybe or against plasma exchange in those kind of poisoning. Somebody has to come forward and do plasma exchange in those kind of conditions. Actually, one case, actually, what Dr. Isha was telling, anaphylaxis because of albumin infusion. So if you find something like that, how will you continue plasma exchange? I think you need to unmute, madam.
Sir, we have stopped plasma exchange for that case immediately. That was the first case we have started. That was a GBS case patient. And that particular albumin, I think that lot we had an issue. So we reported it to pharmacovigilance and we made sure the company retracted that lot, because anaphylaxis to albumin is very, very rare. It has to happen with the composition itself. So for that particular patient, the next procedure also of plasma exchange we have done. From the second procedure, we just used FFP. It was beneficial. Patient recovered within 5 to 6 cycles, if I remember correctly. But we just stopped using albumin because after noticing once, even the patient won't agree to go buy albumin in the first place. So
I think nobody will have that guts to use albumin again. I have seen like even people with paracetamol, optinuron, like many drugs which we believe we use more often. Those drugs also I have seen anaphylaxis. You never know how a patient will react to what drug. So I think what is you believe, ma'am? I think we'll take one after one, like Shamee ma'am, then Divya ma'am, and Dr. Isha. What will be you believe the future of plasma exchange? Where we stand now and what might be the future?
Yes, if we look at IVIG and Indian scenario, plasma exchange is cost effective. First point. Secondly, with the introduction of adsorption columns, we can specifically remove the unwanted substance and infuse the autologous plasma. That is quite beneficial for the patient, and we can avoid allogenic human products. So I feel as we explore the utility on newer indications, so it will be good.
Anything, Divya ma'am?
I think it's basically those desperate measures that lead to newer indications being found out. So whenever in the ICU, you're trying to find a suitable treatment modality for a patient, and you give some treatment, it doesn't work. You give another treatment, it doesn't work. And then probably it comes to your mind that probably a plasma exchange would work. And that is when we unintentionally find new indications for plasma exchange. So this year also we've got the new guidelines, and they've added new indications. One of them is vaccine-induced ITP, which people started facing after they started getting vaccinated for COVID. And when they didn't know what to do, and they had such refractory cases of ITP post-vaccination, they tried plasma exchange, and it was included as a potential indication for plasma exchange. So this will keep on increasing only. We might find more indications where this is of use in the patient population. I have a huge experience in ABO incompatible and HLA incompatible transplants, and I would like to add that therapeutic plasma exchange in the whole desensitization protocol and post transplant, when the patient faces an antibody mediated rejection, that is actually the backbone of your transplant program. And a transplant program without therapeutic apheresis as a treatment modality does not fare well. So it is very important for anybody who wants to establish a transplant program at their center.
Yes, madam. I think we didn't touch on that. Anything, Dr. Isha, you want to add?
Yes, I feel there are newer indications for which plasma exchange is coming up based on case reports and case series. But I feel currently plasma exchange is being underutilized. So a lot of people need to be sensitized on probably the safety of plasma exchange, why it is safe and effective, and also it is cost efficient in Indian scenario, like ma'am has said rightly. Compared to IVIG, it is almost 50% the cost if we sit and actually calculate. So it is underutilized hugely. I feel there should be a lot more awareness on it. Yeah.
Actually, before closing, I think we are shooting our time limit. There was a question actually, if somebody is requiring plasma exchange and patient is having renal failure, requiring dialysis for the same, do you believe plasma exchange will add more volume to the patient? Shamee ma'am, anything? Can we decrease like the volume, what we are taking out and giving to the patient? Can we have a negative or positive fluid balance when it comes to plasma exchange? Maybe that might be a better question.
Yes, yeah. Generally, in such patients, we maintain a negative balance. And in our center, our nephrologists prefer doing TPE first and then dialysis, so that whatever they want to maintain the hemodynamic balance, they do it, they correct it later on.
Maybe the last question is my personal one or two doubts that I will just clarify, because if people are there around whom we can ask always. One thing is when somebody is on, let's say, a patient who is on multiple medication, maybe immunosuppressants or pulsing steroids and all those things, and we are considering plasma exchange in those cases, I believe plasma exchange will remove all the drugs. So is there any literature or guideline how much to supplement? Is it the same amount what we are going to supplement, or like when we are going to supplement? Is there anything, any clarity on that? The dose supplement, because in CRRT we see like most of the drugs we give again the full dose, or during CRRT we continue the patient irrespective of the renal function, we give the full dose of the doses. I know like we need to avoid any medications during that plasma exchange period, but after that, what should be the dose? Shall we repeat all the doses whatever we have given over a period of time, and what should be the time frame? Divya, ma'am.
Yes. So basically, I mentioned this earlier also. Whatever drug we are talking about, we need to know what is the volume of distribution of the drug. So any drug which has a low volume of distribution and it is bound to albumin. So anything that has more than 80% binding capacity to albumin will be removed with plasma exchange. Now, one thing that we should do, that any sort of injectable should not be given immediately prior to plasma exchange, because that will be removed during the exchange. What we can do is maintain a sufficient interval between the drug and the exchange. Preferably, the infusions or any injectables should be given after the procedure. One thing more is, if any drug completes a half-life before you start a plasma exchange, the chances that it will be removed from the circulation are very less. And you might not want to, you might not need to give a supplemental dose. But if the half-life is not complete by the time you want to start a plasma exchange, then you would want to increase the dose of that drug.
I think nicely told, man. I think we are over time now, and thank you very much, like both the panelists, Dr. Shamee and Dr. Divya, and our presenter for today, Dr. Isha. I think we had some good discussion with some practical points. What I also acquired some knowledge out of today's session. I believe a lot of people might have benefited out of this. A lot of people, they see all our this webinar after posting today for maybe for months together. Also, people will follow our these sessions, whatever we have discussed. Mostly practical points we have discussed today, and I thank both the panelists and our presenter. Thank you very much, ma'am, and thank you very much, Dr. Isha, presenting a nice case and generating so much of discussion on this plasma exchange. I hope that we'll use more often plasma exchange, and we could able to convince our physicians and all to go for plasma exchange above IVIG. Nowadays, I believe IVIG is people are preferring more over plasma exchange, and maybe in future I will be using in sepsis and see how a plasma exchange helps in sepsis patient. Maybe the newer guidelines also going to come maybe in sepsis. That is a dreaded complication what we see in and out in our issues. And we sometimes when the patient of severe sepsis with multiple organ dysfunction, we don't have any answers apart from the antibiotics. So with that, I think we'll close the session. Thank you very much. And I thank all the attendees today who has attended the session. Thank you, ma'am.